Thank you very much for the invitation and good morning to Brazil. My task today is to give some overview on diabetes management in chronic kidney disease. Here is my disclosures on the next slide. And I will mainly focus on the new KDIGO Clinical Practice Guideline on Diabetes Management, which have been just printed in Kidney International in the October issue. And I think this is the best example. In the moment, it's freshly published, prepared by the working group to talk about a comprehensive diabetes management in CKD. So on my next slide, I start with the evidence review. Usually KDIGO is doing. They use the Cochrane instruments, and they have some very critical outcomes after asking some important questions. And the clinical outcomes are strong endpoints, such as all-cause mortality, end-stage kidney disease, cardiovascular outcomes, so-called major adverse cardiovascular events, which is myocardial infarction, stroke, and they add also heart failure to the questions. The kidney outcomes are doubling of serum creatinine or reaching end-stage kidney disease. And there are also some questions about hypoglycemia and hemoglobin A1C. Other important outcomes are albuminuria progression for us nephrologists, which are more or less accepted or not so accepted by regulators. So, in patients with diabetes, the guidelines mainly focus on comprehensive care, glycemic monitoring and targets, lifestyle interventions, the antihyperglycemic therapies, and approaches to management, which I mainly will follow today in my talk. So comprehensive care in patients with diabetes and CKD mainly is standard of care, which can be done in mostly all countries in the world, is not so dependent on money and investments. And there is a practice point issued by KDIGO saying that patients with diabetes and CKD should be treated with a comprehensive strategy to reduce risk of kidney disease progression and cardiovascular disease. And this is established treatment, standard of care consisting of RAS blockade, an ACE inhibitor, or an angiotensin receptor blocker, blood pressure control to target levels, but also lipid management is in the package of cardiovascular risk reduction, lifestyle, physical activity, smoking cessation, nutrition, and aspirin only for cardiovascular disease. It's certainly admittable that not every point of this comprehensive care can be managed by every patient, but should be approached as best as possible. So the recommendation which we give for a comprehensive care and specific focus on ACE inhibitors is we recommend the treatment with an angiotensin converting inhibitor or ARB is be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications should be titrated to the highest approved dose that is well tolerated. And you see the grading. The grading is 1B. 1 is we recommend, 2 is we suggest. And B is quite a high level of evidence, so it's close to the truth. The higher grading is 1A. So 1B, with the studies we have, the randomized treatments with less uncertainty is nearly a recommendation, which is very strong. And there are nice algorithms in the KDIGO guidelines, which are good to study. You initiate your ACE and ARB, you monitor serum creatinine and potassium within 2 to 4 weeks, and you look for high potassium hyperkalemia. In very few patients, there is on the right side, a more than 30% increase in creatinine, And then you should review whether you can continue your ACE or ARB inhibitor treatment. There are a few other guidances in this chart which can be used when you install ACE and ARB inhibitor treatment. In patients with diabetes, you also monitor glycemia and glycemic control, and you have targets. Therefore, I would shortly go over these targets. Glycemic monitoring and targets in patients with diabetes and CKD is a recommendation which is also quite strong, is a 1C. And it says that we recommend an individualized hemoglobin A1C target ranging from 6.5 to 8 in patients with diabetes and non-dialysis dependent CKD. And you see that a physician has some liberty to provide an hemoglobin A1C treatment which carries hemoglobin A1C lower to 6.5, or if he decides to stay at 8, which is, according to cardiovascular or diabetes guidelines, pretty high. But we respect here chronic kidney disease. So the respected issues are the severity of chronic kidney disease, the micro and the macrovascular complication. Old age is certainly to be respected, or short life expectancy. Resources of hypoglycemia management absent mainly in parts of this world. Hypoglycemia awareness, so avoid hypoglycemia, and the propensity of treatment to cause hypoglycemia, so other comorbid diseases or other medications. So you can, by sitting in front of your patient with a guideline of 1C, with some flexibility to decide what treatment this individual at this stage in his life requires and what are the goals of this individual. And I think this liberty is something we nephrologists appreciate a lot. Then there, to receive this approach or to approach these targets, I walk to the next point, which is lifestyle intervention. Lifestyle intervention in KDIGO guidelines mainly focus on protein intake, salt intake, and physical activity. Protein intake remains at the old targets, and I will focus shortly on this. So lifestyle intervention is a recommendation saying we suggest. That's a weaker recommendation. It's not a guideline, it's more a guidance to guide nephrologists to maintain protein intake at a level of 0.8 gram of protein per kilogram body weight per day for those with diabetes and non-dialysis CKD. The evidence is not very strong for diabetes. So you see that there is a 2C, which could be interpreted as a bit far from the truth. It may help in certain individuals, but it will not help other people. And therefore, the goal to go to 0.8, which is more or less a normal protein nutrition for normal weight people, is rather according to the discretion of the physician. There are some practice points which go further in detail into hemodialysis and particularly peritoneal dialysis. They should consume higher protein, 1 to 1.2 gram per kilogram per body weight per day. That's mainly due to the protein loss, the amino acid loss during dialysis and during peritoneal dialysis across the peritoneal membrane. And these patients require better nutrition with more protein. There is also a recommendation for physical activity, and this recommendation reads, and it is stronger, it's not suggest, it's recommend that patients should be advised to undertake moderate intensity physical activity with a cumulative duration of 150 minutes per week, so 30 minutes on most days of the week, similar to cardiovascular guidelines, or to a level compatible with their cardiovascular and physical tolerance. That's at least a 1D, which is a recommendation which has some flexibility adapted to the tolerance of the patients. Can be also adapted according to weight. Massively overweight patients may not adhere to this recommendation. Lifestyle interventions in patients with diabetes and CKD focus on the reduction of salt intake. And there is a nice cartoon for many parts of the world. There are 10 ways to cut out salt. So let's start on the left-hand side. When we read the labels, then we should choose lower salt brands when possible, and the goal is less than 2 grams of sodium per day, not to mix with sodium chloride. That's a higher target, but 2 grams of sodium per day is the goal. And the salt in brands is something for very developed countries which really have these salt branded on nutritional products in supermarkets. Then use sweet, sour, bitter, and spicy or hot flavors to replace salt instead of salt. Use unsalted butter. There are salted butters around of the world. Cook with oils or other unsalted fats. Or in Asian countries, could cut salty sauce like soy sauce. So recommendation for every country. And I recommend you just go to KDIGO website and download, free download of this Kidney International recommendation, and walk through this and handle it to your patient. That's a really appropriate way when we go with salt reduction in nutrition, which is quite tough for patients when they cook their own feed or when they eat out of their houses. So let's come to antihyperglycemic therapy and all the modern data we received during recent years. So there is a consideration for glucose lowering medication after metformin and SGLT2 inhibitors. Interesting that these two drugs are coming very high in the place in these guidelines. And there are less suitable medications, more suitable medications, and a preference when comorbidity or other characteristics are prevailing. And you have a number of anti-glycemic therapy, from TZDs to DPP-4 inhibitors, sulfonylureas, or insulin, and the modern ones, more expensive GLP-1 receptor agonists or SGLT2 inhibitors. And you can here choose your medication according to the risk of the patient, comorbidities, and whenever appropriate. There is a very nice cartoon pointing out on, in the first place, lifestyle therapy. Lifestyle therapy in the first place is physical activity, and we discussed it, is nutrition and weight stabilization or weight loss. And if you as a nephrologist have then to think about further treatment beyond lifestyle, you primarily think about, do I have to care for glycemic control, or is primarily organ protection the topic? And when you decide that this patient has to improve with glycemic control, your basis is metformin. If you think that he is walking towards dialysis or has cardiovascular disease, then you choose an SGLT2 inhibitor. Most likely patients are starting with metformin. And then when they have organ damage later on in their career, you could add an SGLT2 inhibitor next. There are restrictions for these two medications. Metformin has to stop at an eGFR at around 30 because of the lactic acid danger, and discontinue below 30. In many countries in the world, you cannot use an SGLT2 inhibitor below eGFR of 60, in some countries 45, or many countries already have opened up to an eGFR of 30 for use of an SGLT2 inhibitor treatment therapy. But then you can continue with treatment, and only when the patient progresses to dialysis, you discontinue the treatment. Whenever there is further glycemic control necessary and additional drug therapy is needed for glycemic control, then you have a wide choice of anti-glycemic treatments. If the patient has still cardiovascular disease, then the GLP-1 receptor agonist is the preferred one. Whenever the patient is with his hemoglobin A1C above target and you want to add, then you can add whatever is appropriate in your country. You choose an DPP-4 inhibitor, you go on insulin or remain on sulfonylurea. However, sulfonylurea is going along with a higher risk of hypoglycemia than, for example, DPP-4 inhibitors or SGLT2 inhibitors. So that's the main message: organ protection versus glycemic control. When we move ahead to the trials we have, then we can distinguish today two sorts of trials. On the left-hand side, the cardiovascular outcome trials, and on the right-hand side, the renal outcome trials. Cardiovascular outcome trials are mainly including patients with relatively preserved kidney function, and they have enriched only a bit, so that in EMPA-REG outcome, approximately 26% of patients have an eGFR below 60 and less in the CANVAS program or declare TIMI 58 with canagliflozin and dapagliflozin as the intervention. The renal outcome trials, where the kidney is in the primary endpoint, accumulate especially kidney patients. And the CREDENCE study with diabetic kidney disease and the DAPA-CKD with diabetic and non-diabetic chronic kidney disease has accumulated more patients which have a mean eGFR of 56 and an albuminuria of about 1 gram per gram. So urinary albumin to creatinine ratio is close to 1 gram. And similarly to DAPA-CKD, the patients have an eGFR of 43 and a UACR of about 1,000. So these trials, and especially the DAPA-CKD trial, which has been presented 3 weeks ago at the end of August at the European Society of Cardiology, shows us a very prominent reduction of the primary composite endpoint. This endpoint includes sustained more than 50% eGFR decline, end-stage kidney disease, renal or cardiovascular death. Here you see the risk reduction, which is about 39%, very prominent risk reduction, and the narrow confidence interval and the high p-value. But more important for us clinicians is to look at the number of events, and they are reduced from 312 to 197, and the number needed to treat is 19. More important, if you look at the y-axis and the cumulative incidence, it's not only a few, it's about 20%. Every fifth patient has an event, and this event is reduced prominently, and the curve is opening up after 8 months. The antihyperglycemic therapy in patients with diabetes, the recommendation is that in patients with type 2 diabetes, chronic kidney disease, and eGFR above 30, we recommend that metformin is used as first-line therapy. And with type 2 diabetes, CKD, and EGR above 30, and cardiovascular disease, we recommend including an SGLT2 inhibitor in the antihyperglycemic treatment regimen. And this is a 1A that's close to a must. So finally, in patients with diabetes and CKD, there is also a general recommendation as to approach to management. The approaches to management of patients with diabetes is that overall we should apply a structured self-management educational program, and this should be implemented for care of all people with diabetes and CKD, and that's pretty a strong recommendation of 1C. All healthcare systems should consider implementing a structured program providing education on self-management for these patients, considering local context, cultures, and availability of resources. Science is global, but implementation is local. So the key objectives are that all people should learn more about diabetes-related complications, improve self-management and self-motivation, and improve and know their vascular risk factors, increase engagement in medication, glucose monitoring, and complications, reduce the risk to prevent diabetes-related complication. And this is more or less primary, it's an early intervention. So I have a patient, and I could go shortly through my patient. He's a 67-year-old male. He has a glomerulonephritis and type 2 diabetes diagnosed 4 years ago, with chronic kidney disease in these stages, which means close to 61 ml per minute and an UACR of 1 gram. Here is the blood pressure, the BMI, the LDL cholesterol, hemoglobin A1C, and he is saying that he struggles with lifestyle. He also has 6-7 pills per day. And this is the treatment consisting of an ACE inhibitor, calcium channel blocker, cholesterol lowering, metformin, and DPP-4 inhibitor. And I wonder, what should I do with these patients? Work on these not at target suboptimal treatments, or go to directly into SGLT2 inhibitor. If I do not go directly into SGLT2 inhibitor and complete my standard of care program, then I instruct him with salt ingestion. He's walking to the cardiologist, to the eye clinic, to foot care, and I lose my kidney focus. He should come at 3 months, back at 3 months. Usually he comes at 6 months because he forgets, most patients. He came back after 6 months. His blood pressure has decreased under SGLT2 inhibitor. He is a dipper. I don't care about his dipping of eGFR, and he has overall improved. So I think we are at a stage today where we have some studies coming in, and some important studies already have been published and will be published. Here are the trials which are ongoing or published, which will give us nephrologists a new opportunity for the future to treat our patients and prevent dialysis. And here you see the work group who worked on this program for the last 2 years. And now you have all the beauty of the new science and the recommendation in front of your table. So I thank you very much for your attention. Thank you.